Good morning. Thank you everybody for coming. We're here excited this morning to listen to Dr. Farah Chuong talk about IVF and go over from her standpoint what it's like and what to offer women with different options. I'm Tracy Milgram Posner, the founder of BRCA Strong. We're here to educate, inspire, empower, and advocate survivors, and thrivers to help them eliminate the feeling of isolation and help them feel whole again. We do this by funding women post-mastectomy garments, doing fashion shows, photo shoots, transformational women gatherings, and just come together to eliminate, being left alone during these times. During COVID-19, we are offering packages for people who are going in for mastectomies or starting treatment. We're here to send them a wellness package. If you or anybody know somebody in need, please feel free to reach out to myself, Tracy, on Instagram or on Facebook or through our website at www.brcastrong.org. And good morning, Dr. Chuong. Thank you so much for coming. We are so honored to have you here today and look forward to all this pertinent information that I know wasn't available 15 years ago.
Yep. All right. Well, thank you so much for inviting me, Tracy. I'm really excited to talk about this. This is something that's near and dear to my heart and is really a passion thing for me. And so when Tracy reached out to me, she was really asking, for what is the role for IVF in patients that have been diagnosed with BRCA. But I want to back up just a little bit and talk about, genetic testing. I'm not a genetic counselor by any stretch of the imagination, but genetics is a big part of my practice. And so I do want to just touch on a few things. And so when patients come to me when trying to conceive, or if they've come to me with a prior diagnosis of some sort of genetic condition, we always do something called expanded carrier screening. Okay. And so traditionally the way that it's worked is patients were screened based on their ethnicity. Meaning if you were African American, you would get like a hemoglobin electrophoresis looking to see if you carried things like sickle cell. Or if you were of European descent, you might get, cystic fibrosis testing, but, not so much in an Asian population. But as the world has become one big melting pot, and as people share their genetics with different people of different cultures, it really has become kind of a big melting pot that something called expanded carrier screening has really taken off in the last few years. And so what we are doing is for patients when they first come to the office, in addition to taking a family history, we also offer something called expanded carrier screening. These are genetic tests for recessive conditions. So if you think back to your biology days in school, you carry 2 copies of each gene in your body. And so if you have a recessive condition that you're a carrier for, you have a good copy and a bad copy. And for you to be affected by something, you have to inherit 2 bad copies. So you and your partner, for an autosomal recessive condition, need to be both carriers for the same condition. And since there's such a blending of genetics now, just doing solely ethnic-based screening is not something that is recommended. And so all patients that come through our practice get screened. And I would say majority of IVF practices around the country do the same thing. ACOG, which is the American College of Obstetricians and Gynecologists, recommends screening for some specific disorders like spinal muscular atrophy, cystic fibrosis, Fragile X disease. And so there are a bunch of other things that are tested for in this panel. It's the one that we use tests for like 283 different conditions. But in addition to testing for recessive conditions, you can also test for some autosomal dominant conditions. And so autosomal dominant conditions are different in the fact that if you inherit 1 bad copy of the gene, then you can be affected by it. Genetics are very complicated, and whether or not you express a full mutation versus have variable way that you express it can be determined on how much of the gene is affected, where the mutation is. And that's why working hand in hand with a genetic counselor is so very important for this. So for example, for BRCA, right? BRCA is an autosomal dominant gene. And so when patients come to see me, I screen every patient that comes through my practice with a thorough medical history, including their family history. What I'm looking for in that family history are clues of that they could possibly be a carrier for a hereditary cancer syndrome. So if they have a first-degree relative that has been affected by multiple cancers, that can be a sign that you could be a carrier for hereditary cancer syndrome. If you have multiple family members that are affected with the same type of cancer, that can also be a clue that you are a carrier for a hereditary type of cancer. If you have a family member that is affected by a cancer that's not really prevalent in their gender, like for example, a male with breast cancer, that could be a clue that you're affected by a hereditary cancer syndrome. And then there are certain ethnicities that are more predisposed, right? So knowing that if you're from Ashkenazi Jewish descent, that you have a 1 in 40 chance of being a BRCA carrier is a huge thing to know, right? And so there are some people just by their ancestry that should qualify for testing. And so when patients come to my office, they get screened for these things initially. And then if they check some of those boxes that I just mentioned, then I refer them to a genetic counselor prior to proceeding with treatment to see if they qualify for testing. Okay, and so then once they go through the genetic counseling with the genetic counselor, if they elect to be tested, because not everybody elects for testing, you know, that's a voluntary thing. And so if they elect to be tested and then they come back and they're positive for something, or if they have a family member that is known to carry the mutation, right? So if somebody comes to me and says, my sister at 35 had breast cancer and she's known to be a BRCA carrier, then I'll refer that patient to a genetic counselor so they too could be tested. And once they have that information and they've been counseled about that, then the decision is, well, what do you want to do with that information? Okay, and so there are some patients that once they find out that they're a carrier for these things, they want to eliminate or minimize the risk to their offspring or to their children. And that's where kind of my role in all of this comes in. But, you know, I would be remiss to not mention that, you know, like I mentioned, genetics is really complicated. So you can be a carrier for something and not necessarily have it, right? So just because you have BRCA does not mean that you will get breast cancer or ovarian cancer. You are at an increased risk for it. And so, you know, some patients elect not to do things like IVF with genetic testing, but others want to eliminate any possibility and minimize their risk. So, but I'm all about informed consent, and I'm all about patients understanding their risk and knowing, you know, what their options are so that they can make the best decision for what their family needs. And so once a patient has been identified as at risk for carrying one of these things or has one of these mutations, they come to me and we have a discussion. The first step for any patient that comes to the office is really to do a fertility evaluation. And you say, well, why is that the case? Like, why do you have to do a fertility evaluation? Well, because 1 in 8 will suffer from infertility. So if you haven't been trying to get pregnant, and now you have this reason that you're doing treatment, but there could be an underlying fertility issue that we weren't aware of, okay? And so we do a basic fertility evaluation for all patients that come in. We also will do the expanded carrier screen that I mentioned before that talks and looks more at the recessive conditions, because just because you won the genetic lotto for one thing doesn't mean that you can't be a carrier for other things as well, like cystic fibrosis, right? So if you're going to go through this whole process, you want to make sure that there's nothing else that you're at risk for that could have a significant effect on your child. And so once the couple has undergone their fertility evaluation, then we talk about treatment. And really the option for genetic testing has to do with using something called in vitro fertilization, or IVF, with pre-implantation genetic testing, which is PGT is the acronym for that. Now, PGT has different ways that we use it. One way that's commonly used is something for something called aneuploidy, meaning just checking for whole chromosome abnormalities. So if a couple is coming to me for infertility and they're doing IVF, they may do genetic testing of the embryos for PGT for aneuploidy, which is just looking to make sure that the embryo is chromosomally normal. Has nothing to do with a specific genetic condition, okay? What we're talking about today is something called PGT-M, or PGT for monogenetic diseases. And this is what this process is it's a little bit more in depth. From the patient perspective of things, the process looks very similar, but what is done in the lab is a little bit different. So I'm going to back up and talk about IVF as a process, and then we'll talk more specifically about how we genetically test these embryos, okay? And so when a couple wants to do PGTM for a specific genetic condition, the first thing that we do is they go through an IVF stimulation. IVF is a process where we take medications, which are purified gonadotropin hormones, which are hormones that are produced in your brain, and we give them to you at super physiologic levels, meaning higher levels than your body normally makes. And the reason for this is each month your ovary has a group of follicles that's available. And what happens is normally you have one of those follicles that you ovulate, and then that's the one that either you get pregnant, it fertilizes and implants and you get pregnant or not, and then you get a period 2 weeks later if you're not pregnant. What happens with IVF is that group of follicles that's available, we give you these hormones to stimulate that whole group of follicles, okay? So each month in a natural cycle, you have 10, maybe 20 follicles available, and one of them you ovulate, the rest die off. With IVF, the name of the game is to try and get all of those follicles to stimulate so that we can extract eggs from them, okay? Each follicle carries an oocyte in it. So during the IVF stimulation, you're taking hormones, and you're on these hormones for 10 to 12 days. During that 10 to 12 day time period, you're being monitored very closely with ultrasound and blood work to make sure that you're responding to the medication, but that you're not over-responding and getting sick, okay? Because one of the feared side effects of IVF is something called ovarian hyperstimulation. Also, with people that have BRCA or a personal history of breast cancer, if they're ER or PR positive, they're particularly sensitive to having high hormone levels. So there are different stimulation protocols that we use to keep the estrogen levels lower in this patient population, okay? And once we have the group of follicles growing, once they reach a mature size on ultrasound, we give a shot to trigger ovulation. But before you ovulate on your own, we have you come to the office, and there's an anesthesiologist here that will give you sedation. And then we extract the eggs while you're sedated, okay? The egg extraction process is basically an ultrasound, just like you've been having during the monitoring phase of the IVF process, except this time there's a little tiny needle attached to it, and the needle is put into the follicle in the ovary, and the fluid from the follicle is aspirated. And with that follicular fluid comes the egg, okay? I give that follicular fluid to my embryologist, and they identify the oocyte or the egg. And then that day is when your partner provides a sperm sample, and they inseminate the egg with the sperm. The next day we know if they fertilize or not. And then we follow them in the lab for about 5 days until they reach a stage called the blastocyst stage. A blastocyst is a stage of embryological development where there are cells around the edge of the embryo that will become the placenta. They're called the trophectoderm. And then there's a ball of cells in the middle called the inner cell mass. The inner cell mass is what becomes the baby. The trophectoderm is what's going to become the placenta. So at that point, the embryologists are able to take a few cells from the outside of the embryo, what will become the placenta, and they take those cells and they freeze the embryo, and then they send those cells off to a genetics lab. Now, I mentioned that there are different types of PGT. There's, for chromosomes, there's for monogenetic diseases, there's for something called structural rearrangement. If you have a known chromosome break in your chromosomes, there's a way to check to make sure your offspring don't have that. So there are different ways to prepare the DNA from those cells for testing. Now, specifically for patients with BRCA, what happens is once you've been identified with a mutation, prior to doing IVF, we make a probe against the mutation that you have. So the patient has their genetic testing, they have their mutation identified. At that point, what we do is we have them give us a DNA sample, and then the lab, prior to doing the IVF cycle, will make a probe against that specific DNA mutation. And so what they do is then once they have the probe ready, you go through this IVF stimulation, we obtain embryos, we biopsy them, and then we send the cells off to a genetics laboratory. Once they go to the genetics laboratory will amplify they'll isolate the DNA from the cells, amplify it, and then they'll test it with that probe to see if the embryo is a carrier for that mutation or not. So you can identify which embryos are carriers and which are not. And then they also do, at the same time, to make sure that the embryo is chromosomally normal, because it does no good to know that one's not affected by BRCA, but then it has trisomy 18, right? And so they check chromosome status, and they also check to make sure that it's genetically not affected by the disorder. Then once you have the embryos identified that are chromosomally normal and not affected, then at that point, on a subsequent cycle, your body is prepared for something called a frozen embryo transfer. So all in all, from the time you start this process to the time you have a transfer is usually about 3 months. Sometimes the probe development for the BRCA mutation can take a few weeks to a month beforehand. So sometimes it can be a little bit longer than that. But generally, I tell patients it's about a 3-month process from the time we start this to the time you have an embryo transfer. And then once you have an embryo transfer, 9 days after the embryo transfer, you know if you're pregnant or not. And so that's kind of like the broad overview of what the process looks like and how it works. Okay. I'm happy to answer any specific, because I just hit you with a lot of information. So I'm happy to answer any questions that you have about how that process works or anything specific about it.
Does anybody have questions now, or do you guys want to wait? It's up to you. Does anybody have questions? Oh,
I was somewhat familiar with the process. I mean, not the details. So, and just hearing you talk, I think it's great to have more details, but I'm not a patient, but I realize that it's a lot of information. So I can only imagine how overwhelming it can be for a patient. And, given there may be their medical history as well on top of this. So what's the is there any counseling that's offered, psychological counseling that's offered or that's recommended, or how do you accompany those patients?
Yeah, that's a great question. So the things that I just discussed with you are generally spread out over multiple consults. Like the first is like doing the inpatient intake, then they do a fertility evaluation, and then they come back after they've seen a genetic counselor. So all of this is done in a stepwise progression. So yes, the information is digested into bite-sized pieces. But your question about psychological counseling and support during this process is huge. Okay, and so I work very closely with a lot of reproductive psychologists with my patients. Treating their anxiety about this process is a huge portion of what I do in the treatment plan, right? And so some patients will use a reproductive psychologist, some will use, acupuncture or different things. There are lots of adjuvant therapies that are used when going through an IVF process that all have their benefits, especially when speaking about, the patient as a whole and not necessarily just on IVF outcomes. Because if you look at things only through one silo, sometimes you may not be able to see the benefit of it. But as the process in the whole, this can be life altering. To get a diagnosis of having, it is life altering. To get a diagnosis of being a carrier for something like BRCA, or having multiple family members, affected by this disorder, and having lived it and walked a mile in those shoes, it is a huge process. Okay. And so supporting these women is a very big part of the process. So yes.
That's awesome.
Joe, did you have a question?
When you reimplant the frozen embryo, do you just because I've heard that with IVF in general, it increases your chance of twins and triplets because you implant more than one embryo. Does that happen, or does that not happen anymore, or is that changed?
That's a great question. And yes, so in the past, IVF was the biggest culprit for multiple births, right? And part of the reason for that was because we were transferring multiple embryos, because our freezing techniques weren't as good. We didn't have genetic testing available. But really in the last 5 to 10 years, genetic testing of the embryos has really taken off. And really in the last, I would say 5 years, it's become kind of the mainstay of treatment. And so the field of reproductive endocrinology really has moved towards doing single embryo transfers at this point. And so when you put one embryo back, the likelihood that that embryo splits into 2 or more is very unlikely.
Yeah.
But if that happens, they're identical twins, and it's not because we were putting back multiple embryos.
Okay.
That's a great question, though. Yeah.
Does anybody else have any questions?
So,
Mhm.
oh, go ahead. Go ahead.
When you talk about, like BRCA carriers, for example, right? How, I guess, like, is there any research on like the embryos, like not transferring and then like going through that process and then still getting back from the lab, there's still that mutation? Like, does that happen? Is that common?
So it is, so PGT is good, not perfect, right? But the level at which they look and they amplify the DNA for genetic testing for a monogenetic disease, meaning when they're testing for a specific genetic condition, the level in which they amplify the DNA and the way that they look at the mutation is very different than when they do whole chromosome looking. And so because the whole reason that you're doing this is to eliminate that gene, right? And so can I say for 100% certainty that it eliminates it 100%? No, but it is very unlikely that the embryo would be affected. The reason that I can't say with 100% certainty is not because of the technology of amplifying the DNA, but there's something called, and this gets a little bit complicated, it's called mosaicism, where if you imagine the outside of the embryo, the trophectoderm, looking kind of like a soccer ball, right? And so some of the cells are white and some of the cells are black, just for a visualization, right? The white ones being chromosomally normal, not affected, or the black ones being abnormal and affected, right? And so it's possible that you biopsy just the white cells and miss the black cell,
Okay.
and so it's unlikely to be for a genetic disease that way, because it's you're amplifying the DNA and looking at it very closely, but there can be a sampling error. And so it's something to talk about, but unlikely to happen. Okay.
Any other questions? Nope.
All right. So then the other thing to talk about is, I briefly mentioned it, but with patients when diagnosed with BRCA, right, it's like being hit with a freight train. And so they have to process their grief about, the diagnosis and what that means to them. And then, some people internalize and process that differently. And some people make a plan and want to be proactive. And some people retreat, right? And so I have kind of the whole gamut of patient populations. But the thing that's important to discuss with them is, and this is where the genetic counseling is really important. Like, I cannot underscore enough the importance of having a good genetic counselor that does this, because when somebody is diagnosed with BRCA, I mentioned that it doesn't mean that they're necessarily going to develop the breast cancer or the ovarian cancer. They're at an increased risk for it. And of course, some of us are completely risk averse, right? Me being one of them. If there's anything I can do to eliminate a risk, that's the route that I'm going to choose. But others, the idea of manipulating genetics, or the idea of purifying their genes, or where their comfort and their ethics and where their morals and where they feel that they're doing too much, I'm very respectful of that, and I understand not everybody feels the same way that I do. Okay. And so it really is a very complex topic. And I just want to let patients know that, like, we are sensitive to the fact that that is a complex topic, and it's not just like, oh, you have this mutation, let's get rid of it and let's move on. That it's very complicated. Just like when you're diagnosed with these things, you're faced with other, aside from childbearing, other decisions about your very own body. And when you're going to do surgery, if you're going to do risk reducing surgeries, if you're going to do the mastectomy, if you're going to do this bilateral self-injectomy, all of these things, it's a very complicated situation, and it takes a multidisciplinary approach to really get at the heart of the matter and find where your balance is and where you're comfortable. But this is definitely an option that patients elect, and it's a very common reason for patients to do genetic testing of embryos, and something that we offer.
It's definitely more common over the years, correct?
Yeah. I would say that very few patients once diagnosed decide not to do it. But that being said, you know, sometimes I have patients that come with the intent of doing BRCA or PGT for BRCA, and then they end up pregnant on their own. They're not necessarily going to go abort a pregnancy because they got pregnant on their own prior to doing IVF, you know? And so like, it's understanding your risk. Again, it's all about education and supporting the women and their families as they go through this.
You know, as you go to different physicians, like for BRCA, once you're diagnosed, or even breast cancer, you know, when are you given the information on IVF? Because, I mean, honestly, we know things change, right, again, but the question is when are you actually given that information to the women? Like, because I remember in my process, yeah, it was 15 years ago again, but I was never given this option.
Right. Because it
Maybe
wasn't really
technology, it wasn't an option,
It was
but like
not an option.
I deal with so many women on a different basis, right? And so many women are not given the information on IVF. And that's kind of why I said to you, let's do it so we can continue to educate. But like, do you think it's the lack of physicians and overwhelming patients? Like, why do I feel like IVF is such a weird topic? You know, I'll even be honest, posting this call, I got a lot of different feedback. You know, I got negative and positive.
Yeah. Welcome to my life. I personally feel like, you know, as soon as you're diagnosed with a mutation, that option should be at least mentioned. Whether it's a one-liner, whether it's a pamphlet, whether, you know, it should be mentioned. That being said, not everybody is aware. You know, sometimes you have physicians that have been in practice for a very long time and it's just not something on their radar, or they get tunnel vision. You know, so when you're dealing with breast cancer and ovarian cancer and that's the way that you look at everything, you know, you're not really necessarily thinking about fertility. You're thinking about, how do I risk reduce this lady's chance of dying of these disorders that I'm treating day in and day out, right? Sometimes I even struggle to have oncologists with patients that are diagnosed, you know, in their reproductive age years with breast cancer before they ever do treatment. I struggle to get the patients to come to see me before they undergo chemotherapy. And ideally for IVF, you do all of those things prior to them receiving anything that can affect their ovarian reserve. Because once you've developed breast cancer and you're being treated with chemotherapy, there are chemotherapy agents that have very harmful effects on your ovarian reserve and your egg quality. And so it's best to take the 2 weeks before undergoing chemotherapy, retrieve the eggs, and then go on with your treatment. But that being said, there are lots of different ways to build families these days. And so if somebody was diagnosed with breast cancer and underwent treatment and didn't have this option given to them, sometimes after you finish treatment, there's still the option of doing IVF with your own eggs. Sometimes just based on the treatment that you received, that's not an option anymore. And then there are options like using a donor oocyte with your partner's sperm and then you still carrying the pregnancy. Genetically, the pregnancy wouldn't be necessarily related to you, but it's still a way for you to become a parent and carry a pregnancy. Again, there are lots of different options available. But again, I am hugely a proponent of knowing your options, knowing your risk, and just giving people information. You know, IVF is not for everyone. It's very much has in the past been a very taboo subject that people don't want to talk about. And so I'm not surprised that you get mixed feelings in response to, you know, why would somebody do that? Or it's a very complicated decision, but it's nevertheless something that's available. And it's important for women to be empowered and be educated to make their own decisions.
Correct. Does anybody have any questions at this point?
I actually do have a question. Sorry, I came in a little late, but I've actually just gone through all of this in the second half of last year. Actually, a year ago, about in July, I was diagnosed with breast cancer. I was 29, I'm now 30. I had a mastectomy last August, and I was supposed to start chemotherapy in October, and I did find out that I also had ovarian cancer. So I had two separate primary cancers at the same time, and I had my affected ovary removed, but prior to that, I did go and have eggs harvested and 3 embryos created. At the time, we chose not to do PGT testing. I think partially because I'm BRCA1, I should mention that as well, which I found out last summer. But I think I was exhausted from all the decisions that I had to make, and we were having some financial constraints as well for the additional cost of the PGT on top of the IVF. So we didn't do that. And we ended up with only 3 embryos frozen. And so now we have the decision to make about whether, if we do end up using these embryos for IVF, if we're going to do the PGT testing now. And I'm having a hard time understanding the level of risk to the embryo to essentially unfreeze the embryo to do the PGT testing, refreeze it to wait for the results, and then unfreeze again for IVF.
Right. So that's a great question, and in a very to the point that I was just making, it's not a slam dunk like, oh, I've been diagnosed with this disorder, I'm going to do genetic testing of embryos. There are a lot of things that go into it, and your story is very familiar to me in the fact that patients go through absolute decision fatigue when they are being thrown. So, especially, I'm sorry that you had the 2 primaries at the same time, but like the breast cancer, the ovarian cancer, like making embryos now, trying to get your treatment done, get your surgery done, like that is a horribly trying time. And so it is not uncommon for patients to say, let me just do what I can do, freeze the embryos, and I'll come back and we can revisit this when I can think with more clarity. In general, I prefer to biopsy embryos before they're frozen, because the process of thawing them, biopsying them, refreezing them, and then thawing them again, you're talking about an embryo that's, a few hundred cells. And so you want to minimize the stress that embryo undergoes. Right. However, you have a very compelling reason for doing genetic testing of the embryo. It's not like you just want to choose gender of the, and know that it's a boy embryo or a girl embryo. And so for that, in this situation, this would be a situation where I wouldn't necessarily discourage you from doing that. We would, I would talk to your doctor that treated you and say, look, I'm ready to revisit this. And also, have this embryo biopsy. The other option is if you just want to know if it's affected or not, which sometimes people will biopsy and transfer that embryo without having the results, but then you get the results back and you would have it just so you would know. But then at that point, if it implants, it implants. You have 3 embryos that are cryopreserved now that you've undergone all the chemotherapy for your ovarian cancer. Did you have follow-up chemotherapy for the ovarian cancer?
I did.
Yeah.
And I'm on Lupron injections for endocrine suppression, and I will be going on some additional type of endocrine suppression. Yeah.
Yeah. And so if at that point, you say, well, we have these 3 embryos and this is what we have, and we don't want to risk not having a child.
Right.
Because that was your window for your eggs, right? The other option, like I mentioned, is if that doesn't work out, or if they're chromosomally or genetically not compatible with you transferring, there's always donor oocyte later on. But of course, you went through this to preserve your own fertility and use your own genetics. And so that's not I'm sorry if it's not a straightforward answer, but it's something that in your situation you can absolutely do. But there is some risk to the embryos by doing the thaw and the biopsy after the fact.
Sure. Okay, thank you.
Perfect. Does anybody else have any more questions? Brittany, thank you so much for coming on and sharing your story. Very empowering of you and inspiring. I appreciate it. And anything we can do at BRCA Strong to help you, please let us know, because I'd love to be able to help you out any way we can.
Same, Brittany. If you have any questions, please reach out to me. I'm happy to help you as you navigate those steps, okay?
Thank you.
Perfect. Well, I'd kind of like to just end the call, unless Dr. Chuong, do you have any other, I want to just kind of end it in a different way than I normally do. I know personally I'm BRCA positive, found out at the age of 21 after undergoing 2 lumpectomies at 18 and at 19. And I know this process was never offered to me, even though I took preventative action 5 years ago. So with this call today, I learned a lot. It actually made me super emotional, knowing the options that are out there. I think just continuously educating, I don't know, a couple people asked me, well, what would you have done? And I'm like, I don't know, because, do we want to mess with the genes? Do we want to alter them? Do we want to see what our kids, our kids go through what we went through? It's a hard subject, and I want to be able to support anybody, no matter what your decision is. There's no right or wrong. I think it's a very personal decision.
100%.
It's just a constant thing is, do our kids have these genes? And I constantly, this weekend I was away and we were talking about it, and I'm like, I sure hope not, but there's a 50% chance. And I'm thankful that technology has come as far as it has, and I have the physician support to just make sure that we educate and guide these women the right way, because you should never feel alone and you should never have to go through this process alone. So I really thank you for your time.
Thank you, ladies, for joining me today. I'm really, this is something near and dear to my heart. And so I'm really honored to be able to do this. If anybody has any questions, I'm reachable through social media or through my practice at any point. And I'm happy to answer questions offline if you don't feel comfortable asking them, in a Zoom format or, face-to-face. Please feel free to reach out to me, okay? But good luck to you, Brittany. I hope
Thank
that
you.
everything goes smoothly with your remission and into recovery.
Thank you.
Thank you so much, Dr. Chuong. I wish you a fast, easy delivery. We will be